So good morning. So I'm an infectious disease doctor, and I like to ask, why do these conditions exist? And my basic tenet is every unexplained medical condition is an infectious disease waiting to be discovered. So there we go. So Lyme disease, spirochete, been around for 100 years, plus neurological disease in Europe, rheumatological disease in America, finally discovered in the 70s in old Lyme, Connecticut, where these kids that had this immunological condition, atypical rheumatoid arthritis, that wasn't atypical rheumatoid arthritis. It was a bacteria, a spirochete, caused by a tick in old Lyme, Connecticut. So we always think about deer, but all sorts of little animals carry ticks, including dogs, to bring them back. So you don't have to be out in the country. You can be in your kitchen. And I have many cases of people that never left their house where the dog brought Lyme back. And I think one of your rugby players got a dog tick. Matt, what's his last name? Dawson, yes. He brought a tick. His dog brought a tick back from Twickenham. And Lyme affects the conduction system through the nervous system. And he had a cardiac ablation before 2 years later he was diagnosed with Lyme. So Lyme is a challenge because it causes lots and lots of different kind of protein manifestations. So as I said, Lyme arthritis, 1975, and then Billy Berdorfer in 1981 identified this spirochete. And ticks carry more than just Lyme. They carry other bacteria. So it doesn't matter if it's Lyme or other bacteria. If you get bitten by a tick and you're sick afterwards, it's possible that it could be a manifestation of Lyme disease or other infections that are carried by ticks. So these are some of the other infections that ticks carry. And these are even more pathogens that ticks carry. So vector-borne diseases, I think, are a missed opportunity. Lots of people are getting bitten and get sick following that. And there's a possibility that there may have been inoculation of bacteria from these ticks or from other infections. This is UCD data from University College Dublin. They went out and picked ticks from different parts of Ireland, ground them up, and, sorry, this slide is not shown here, but they actually identified 3 different bacteria from the ticks: Borrelia, Anaplasma, and Rickettsia. So the ticks around the animals have those 3 bacteria in Ireland. And there's lots of patients with diseases that are kind of not yet recognized that I think we're missing in Ireland and probably in the UK as well. This is a study we did of ticks in Ireland where somebody went out and picked ticks from 6 different sites. And between 2 and 12% of ticks in Ireland are positive for Borrelia. Ireland says there are no ticks, the ticks aren't infected, etc., etc. But actually there are ticks, and some of them are infected with Lyme. And in Porthumna, just interestingly, one of the ticks was not Borrelia burgdorferi, it was actually Borrelia myomoti, which is relapsing fever Borrelia. So which is a different strain, not being picked up by any of the current testing. The Big Tick project that's going on in the UK, they've picked up all the ticks, and I was at a meeting a year ago at Imperial College, and I asked what the results of the Big Tick study was, and one of the leading researchers in the UK basically says, we don't think the ticks have much of anything, maybe Borrelia. And then about a month ago, there was a report of tick-borne encephalitis. It was in the newspaper. There was a patient in New Forest that had tick-borne encephalitis last July, and then the ticks in Dorset and New Forest have tick-borne encephalitis as well. Just pointing out what I was showing you before, ticks carry lots of things, including Lyme. And if you're the unlucky one to get that tick, and we don't have the test to diagnose you, you may have this mystery neurological disease. How common is it? These are studies from the antibody testing in the UK. But these tests don't pick up Borrelia myomoti. They're not testing for tick-borne encephalitis. They're not testing for Babesia anaplasma. So there may be more infections out there than we're aware of. And not everybody gets identified with a tick. This is a study that was done from British Medical Journal where they actually went to GP practices and took a look and said that no, there's not 1,000 or 2,000 cases. From reviewing over 8 million records from GP practices, their estimates were actually based on documented clinical Lyme diagnosis by GPs, 8,000 rather than 2,000. But still in Ireland, they say there's 10 or 20 cases a year. We estimate probably 2,500. In America, they estimate 30,000 CDC 5 years ago. Now with new funding and new studies, they're actually estimating 400,000. So something remarkably has changed over the last 5 years, either global warming or increased awareness and increased record keeping of these infections. So I think lots of ticks go, you don't recognize a tick. Tick is the size of a sesame seed. I had a patient in my emergency room 6 months ago, sent away from the emergency room, a month of pains, fevers. He had a big rash on his back, he noted, and the ID doctor, who I trained, sent him away saying, we never recognized a tick, and that rash was too big to be Lyme. So anyway, he did come back eventually, got a month of doxycycline, and the test that I did was positive for Lyme. Ticks are very small, and we may miss them. So there's potentially lots of people getting tick bites that you don't recognize if it was back here. And then they described the rash. The classic rash that came to my emergency room 6 months ago was sent away because it couldn't be Lyme, it was too big. 50% of people plus don't get a rash. And if you got a rash back here, would you notice it? You wouldn't notice the tick, you wouldn't notice the rash. You might just get a fever and joint or neurological symptoms down the way. And the rash isn't always classical. This was provided by one of the groups to me. It can look different. So what happens if you get Lyme, or you get an infection with Lyme or a co-infection? You get fever, headache, joint pain, fatigue, neurological stuff, joint stuff, maybe palpitations, lots of different symptoms, which kind of overlap with lots of other diseases. So it kind of is a challenge. And these are the symptoms of Lyme disease and co-infections. Neurological, nerve stuff, psychiatric stuff, head stuff, eye stuff, inflammation. So you get an infection, a low-grade infection. I take care of all of the inner city people in Dublin. They inject themselves with Staph aureus. They're dead within 2 days. You get injected with Lyme. It's a low-grade bacteria. So even if you don't treat it, you just get a flu, and then you kind of maybe show up to the neurologist, dermatologist, or rheumatologist, and maybe your test will be positive, maybe it won't be positive, maybe you'll recognize a rash, maybe you won't. So you can have lots of different symptoms, and it does overlap with lots of other symptoms, including PoTS, including atypical rheumatoid arthritis, including ALS. So it can overlap with lots of different stuff. This is the classic Bell's palsy. Not everybody gets the Bell's palsy, but it's an example. The bacteria's in the nerve, the immune system's attacking the nerve, and you get weakness in the nerve. With or without treatment, it can go away. This is the joint problem, and it may show up in weeks, but it might not show up for a year later. And if you'd been in the New Forest a year before, and you all of a sudden you had a flu, and all of a sudden 9 months later you start getting joint pain, you might not think about Lyme. And then there's testing. How good is the testing? It's an antibody test. It doesn't pick up all the strains of Lyme. It doesn't pick up the co-infections. And the UK and Irish government say it's 100%, but it's not 100%. Lots of studies show it isn't. So there's no good standard test. There's no gold standard. We don't have a PCR. If we had a PCR, there'd be no argument. We have immunological tests that may be negative and you have the infection, and it may be positive from an infection from 10 years ago. So an antibody test means active infection or previous infection. So it is a challenge. You have to interpret it, and you have to look at the patient. The patient's perfectly healthy, no problem. If the patient's got a mystery illness and you can't figure it out and you've got a positive test, be suspicious. If your person's got a negative test and they've had an exposure that's very suspicious, a rash 6 months ago, diagnosed as ringworm or a cellulitis that never got better with flu clots, maybe you should think a negative test does not exclude the diagnosis. And these are studies showing the sensitivity of the test, 36 to 70%, 20 to 97%, 30, 40, 50%. I want the 100% test. Okay? So, nice guidelines. If you have a rash, treat, which is great. But most of the GPs in Ireland don't, including the infectious disease specialists that I trained when the patient showed up in my emergency room. And then you treat for 21 days. But I don't treat any infection just for a set period of time. I do outpatient antibiotics. I treat for 3 weeks. I treat for 6 weeks, depending upon clinical response. But for Lyme, for some reason, we treat for 21 days, okay? So it is a challenge. So there really seems to be a poor understanding of this condition and the severity of this condition. People argue it's an autoimmune inflammatory condition. It's probably infectious plus inflammatory and autoimmune. So it really is a challenge. But what if you don't treat Lyme? This is an old study from 1987. If you don't treat Lyme, this is from Steer in Connecticut, 5% get carditis, like our friend, the rugby player. 10% get neurological manifestations, might be meningitis, might be cranial nerve palsies, could be radiculopathies, could be sympathetic, parasympathetic inflammation. And I see lots of patients showing up with bladder inflammation, gut inflammation, and that may be increased, decreased, depending upon what nerves it is affecting. And 60% get arthritis. So, and then people say 3 weeks of antibiotics, Bob's your uncle, you're cured. Probably that's true some of the time if you catch it early, if you catch the rash, but probably not if you're not diagnosed till a year down the way. So there's studies to show that it doesn't work all the time. So 3 weeks doesn't always do the job. Nice suddenly changed from 3 weeks to 6 weeks. Or you can go 3 weeks, and if you're not better, go another 3 weeks. But it doesn't always work 100%. And sometimes you don't even look for the other infections. That's for people who are diagnosed, but what about those who aren't? So there's two different groups, IDSA and ILADS. IDSA is the big kind of powerful 18,000 infectious disease specialists. ILADS is kind of the private group of people who are seeing most of the patients, who have most of the experience, but probably less of the science and less of the resources. So people have different opinions on what you should do. So you should treat people clinically based on your suspicion. If you catch them early, probably they are going to get better, but you really should guide based on response to therapy. NICE guidelines say there's no such thing as chronic Lyme, even though I can show you hundreds of articles that were excluded from the Lyme review, from the NICE review, that persistent infection can persist. People who took a biopsy in research studies grew the Lyme bacteria. I just saw one of those patients 2 weeks ago, a year down the way, biopsied up in Liverpool, a year down the way, and then he got 3 weeks of treatment, and he's still sick, and he's coming to see me. But they actually were able to grow Borrelia down the way, so it does persist for a period of time, and can cause lots of different conditions. Unfortunately, these conditions overlap with lots of other conditions, and they may see neurologists, rheumatologists, cardiologists, and then they've got a set diagnosis. But I always say, if you've got an atypical rheumatoid arthritis, and you've got sweats, and you've got numbness and tingling, you've got bowel problems, bladder problems, and palpitations, maybe it's not atypical rheumatoid arthritis. Maybe you should think together. One unifying diagnosis, rather than their sweats are from being menopausal, and their neurology is from FND, functional neurological disorder, and they've got atypical rheumatoid arthritis as well. Infections cause protein manifestations. The rule of medicine is really to put things together, not to put them apart. And we don't seem to do that. IDS says there's no convincing biological evidence for the existence of symptomatic chronic B. burden infection among patients after receipt of recommended treatment. 2 weeks of treatment, Bob your uncle, you're cured with doxycycline. It's post-infectious. I'm not that good. There's no PCR test that can show it's post-infectious. In my experience, in some situations, if you treat longer, they get better. So if you get better with an antibiotic, you stop it, you get worse, and you start again, you get better. That's an antibiotic effect. There's an infection there. It's not post-infectious. So PTLDS, which is what they call it, in many situations stands for partially treated Lyme disease syndrome, not post-treatment Lyme disease syndrome, in my opinion. The ILADs kind of show that there is evidence of persistence. Most of these references, there's about 80 of them, seem to be excluded from people who selectively cherry pick their guidelines. So, what is the concept of chronic Lyme borreliosis? It's a multi-system disease, musculoskeletal, neuropsychiatric, neurological disease, cardiac, from an underlying untreated infection, and probably a cascade of inflammatory and autoimmune processes that are going on. What causes the persistent symptoms? Is it treatment failure? Is it immune dysfunction? Is it tissue damage? Maybe they're not treated, maybe they're reinfected, maybe there's other conditions. There's all sorts of theories, but there's no good science. There's no good resourcing. The only good resourcing that's coming in the world right now is a Cohen Foundation in America, where one of their kids gets sick, and he's a hedge funder, $7 billion worth in New York, and he's put $600 million into Stanford and Hopkins and Tulane and Columbia. And some good work's coming out to support the fact of persistence and biofilm and all of the stuff that we should have learned 30 years ago about this infection. So there's lots of challenges. What's going on? There's limitations with the current tests. There's uncertainties of diagnosis. There's huge polarization within groups as to whether chronic Lyme exists. The current standard from the PHS in the UK and NHS is it doesn't exist. But there's lots of people out there, whether it's PoTS or chronic fatigue syndrome or fibromyalgia or these conditions that are around, and nobody knows what's wrong with them. Right now, people are just treating the symptoms. Get over it. Wellness, get better. Exercise more. So what's known about Lyme and postural orthostatic hypertension, PoTS? The answer is very little, because there's been no investment. Some USA and European clinicians with extensive experience of treating Lyme have observed an apparent correlation between chronic tick-borne infections and PoTS, maybe 10%. These symptoms seem to develop months or years after the initial infection, when the Lyme diagnosis has been forgotten. So this is pretty classic, and it's a plausible explanation. Maybe some cases of PoTS are caused by Lyme, or some other infections similar to Lyme. Maybe there's a pregnant woman who's infected and delivers her baby, and who knows? In follow-up, maybe that baby is infected. Nobody ever thinks about it, okay? We don't know. PoTS Borrelia. Borrelia is known to affect the nervous tissue, and there have been studies dating way back looking at antiganglioside IgM antibodies in a higher frequency in patients. It's been reported that symptoms often improve and sometimes resolve following treatment of the underlying condition. However, there's no good research data to support these observations, no prospective studies. In patients diagnosed with PoTS and dysautonomia, it may be appropriate to consider the possibility of coexistent Lyme borreliosis. It's worth doing the test. We test for syphilis. We test for all these strange, unusual diseases. I test for Lyme. But even if the Lyme test was negative, if you took a good history and there was a rash or there was an exposure, a farmer in Donegal, a farmer down in Waterford, and I've had cases of this, I've empirically treated and they've got better. When I clinically suspected highly that they might have an underlying infection. Okay, so it is a challenge. This is just one case study. I had a second case study of a patient whose mother is in the audience here today, and she's had this mystery PoTS. The patient who is mum's in the audience today come up and said she's doing better. How did I treat her? Combination antibiotics. So she's been years and years in the UK system with these mystery illnesses and adrenal insufficiency, and my combination antibiotics. Because she had testing, she had a history, suspicious, combination antibiotics, they now want to write her up as a case report. But case reports aren't good enough. We need resources and investment. But this is just one case, a 14-year-old chronically ill boy from Donegal, Northern Ireland. And I told you from the studies of ticks there, they have Anaplasma, Borrelia, and Babesia, and all of the farmers and all of the animals, the cattle, the sheep up there. He was diagnosed with CFS, ME, EDS, PoTS, said he had post-viral syndrome. So I think 2 years out of school, lying in bed, his mother, who was an American from Connecticut, thought he had Lyme. She actually was almost prosecuted by the social services for Munchausen by proxy for persisting with this, but nonetheless came to see me. He was kind of lying in a chair. I could hardly draw blood on him. Photophobic, very, very, very uncomfortable visit. And he had the Irish Lyme test negative, did this unaccredited German test that is actually an accredited test done in Finland called the TickPlex Plus, run in an accredited lab in Germany, but it's unaccredited. It's like Chinese whispers. So we don't recognize tests that are accredited because they're run in Germany, but this is an accredited test called the TickPlex Plus from Finland. But he had a positive test for Borrelia and Ehrlichia anaplasma, the same bacteria that ticks are biting the animals in Donegal. I put him in a combination antibiotics, focusing on those two bacteria, cefuroxime, rifampicin, limecycline. Limecycline, kind of like doxycycline, but for longer standing infection, my experience is short course treatment doesn't work. And within 2 months, he was no longer, his PoTS had gone, he was able to walk. And after 5 months, at the completion of therapy, his neutropenia had resolved, his immunoglobulins had went back to normal, his lymphocytes went back to normal, and he was able to return to work. Just a case report, but if it was my son, I'd do what that mother did. I think he had ongoing tick-borne infection that resolved with combination antibiotic. So I'll end now, and there's a few articles up here that kind of talk about persistent infection, treatment with combination antibiotics. And we're running a conference in the 27th and 28th of March in Dublin, focused on crypto-infections, these hidden infections, which I think are much more common, Borrelia being one of those. Thank you.